Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, listeners. Did you know that psychedelic assisted therapy is no longer theoretical? It's now operational. The FDA has draft guidance for psychedelic trials, spotlighting safety, psychotherapy context, and abuse prevention. Esketamine is already in everyday practice under a REMS program that mandates in-clinic dosing and at least 2 hours of monitoring, no exceptions. Meanwhile, multi-site trials suggest that psilocybin, which I cannot say correctly, and ketamine, which is not the same as esketamine, can move the needle in treatment-resistant depression, a population where conventional care too often stalls. The stakes are clinical and practical. Dissociation, blood pressure spikes, and impaired coordination, they're not edge cases, they're expected events that demand skilled nursing. So welcome to our episode on psychedelic assisted therapy and psychiatric nursing. I'm Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Now, for this discussion, I have Dr. Nicholas Goodwin joining. He is a psychiatric nurse practitioner, and he is here to help us get prepped on how we can turn this promising science into safe, repeatable care pathways. Thank you for being here with me today, Nick.
Oh, yeah. Thanks for having me.
Yes. Well,
Awesome.
I really want to start with the beginning. How did we get here? I feel like it's really hot topics now.
Oh, yeah. Yeah. There's definitely, it's very, very interesting to everyone now. And it's cool because it's also becoming more and more available, especially with ketamine and especially with psilocybin.
Yes.
Those are, you can legally sort of get treated with both of those. Ketamine, pretty easily or pretty accessible. Psilocybin legally only in Oregon, but it looks like a lot of states are bringing on pathways for people to get a hold of it. MDMA was potentially going to get approved for PTSD, and they even got in front of the FDA, even though it was denied. So we were, right there. And so it seems like, this is a little tangent, but, when the MDMA was in front of the FDA, senators were calling the FDA, asking them to approve it. So we can't even say the government's suppressing it anymore. The government wants, psychedelics out there to help people with PTSD and depression and the mental health crisis. It seems like a great option and a very effective tool. So it's cool to see that.
Well, now, before we hop into kind of the landscape of where everything is sitting, can you help our listeners understand the difference between the ketamine and the esketamine? Because, they sound very similar.
Oh, sure.
They are very similar.
Yeah. And ketamine was really, I think, where we saw how promising these kind of treatments could be. I think maybe there's an argument it's not quite a psychedelic. It's more of I'm quoting here, dissociative. But it has psychedelic-like properties for a lot of people. And, it was anesthesia. It was an anesthesia med that came out in like the 60s and 70s. And it was a great option, especially for like ERs who wanted to do, simple procedures like chest tube placement or relocating a joint. You give somebody ketamine and you have 40 minutes to do something, and you don't have to really worry about, having an anesthetist there. Their blood pressure won't drop, their pulse won't drop, they keep breathing. And so you have a really great anesthesia option. At some point, they found these really robust antidepressant and anti-pain properties, and people were willing to sort of open up these small practices, especially with some of the studies out in the early 2000s, to offer outpatient ketamine treatment. And that really got the interest going in the world, I think, with the antidepressant effect of IV ketamine and how robust that was. And so, I think once that become more and more normalized, you see Harvard algorithm puts it on their algorithm for treatment, severe depression. You see mainstream psychiatry embrace it. Now you have the pharmaceutical industry interested in maybe benefiting from an agent like this. And so, you can't take an agent that's been generic for 50 years and say it's, brand name now. So you modified it by creating an isomer. So they, there's the molecules maybe kind of like, I've heard the analogy used like two gloves. You have the S isomer and you have, or the enantiomer, and you have the R. And then they go and they look at which one they think is most promising. Maybe the S enantiomer has more of an NMDA blockade than the R, so that's more promising. So let's isolate it and create a novel chemical, and we'll call it esketamine. And then we'll study it and see how it works. And they made it in nasal spray, so you didn't have the burden or the clinical burden of intravenous use. So more clinics could use it. And the studies show that it worked. The studies, I mean, I can go more into the studies if you want to. I guess some studies are positive, some studies are negative, but that's kind of the world of research.
Yeah.
But so that's really the biggest difference is the this is an enantiomer met. I think I tell my patients, it's like, because most of my patients have been on all the SSRIs. So I compare it to Lexapro and Celexa. I don't know if you're familiar with those SSRIs. They took Celexa, it's citalopram. They isolated the enantiomer and created S-citalopram. And escitalopram is probably a little bit cleaner and a little bit more effective than citalopram. A little bit,
Yeah.
And so maybe that's what they're hoping for. You get the same thing with a lot of stimulants. They just keep isolating isomers to try to create novel meds. They all kind of do the same thing. So I don't necessarily think one's superior over another. I think there's pros and cons. I think one pro with esketamine is that you get insurance companies to cover it. Yeah. And that is, this huge conversation with psychedelic and access. How do you make sure people have access? Well, you get insurance to cover it. And esketamine is covered by insurance. So the IV route is the other difference. Most ketamine is given IV route, but nowadays there's a lot of other routes. And I do think the absorption of the route plays a difference in how that medication interacts with a person. But at the end of the day, if they have ketamine in their system, it'll probably work as an antidepressant. Whether it'll work as a dissociative psychedelic experience is the other question.
Right.
That makes sense.
Now, that's kind of set the landscape for us, because I know that there's what's real and then there's what is hyped, what you see on social media, what you see in the news, what you see on reality TV shows. What does the landscape actually look like as far as where we are with the ketamine, the esketamine, and the psilocybin? I can't say that one. I don't know why. I'm looking at it. No.
It's got so many letters. It doesn't make sense. Why are there so many letters?
Silent letters.
Yeah. I mean, the landscape for ketamine is, maybe even, makes practitioners nervous at how much access is coming out. You have the online distributors that are sending it home to people. You have a lot of new manufacturers coming out trying to create new indications for ketamine, which, they're saying, well, that's because we want to improve access and reduce the amount of shortages there are. But it always kind of feels like a money thing. So it's interesting. How far ketamine is going. I think that ketamine is a great option. I don't think there's sort of an end all be all to it. I think there's some limitations to it. And so, kind of promising this cure that you can send to somebody in the mail, it's not telling the whole story, but mental health treatment has struggled to meet the needs of its patients for a long time. So something that works and works well and works fast and people have access to is globally a good thing. But the access is increasing and increasing. As far as psilocybin, I mean, a lot of states right now are having legislation where they're going to be able to start offering it. And even Oregon is offering it as well. It has started offering it in non-medical clinics. And so these are clinics that are not run by health professionals. They're not treating disorders. It's really, people are going there for the psychedelic experience, for the, the interpersonal experience of learning about themselves and, all those benefits of psychedelics that really seem to transcend illness and transcend symptom response, which is what makes it really difficult to get these meds approved. So in a way, it's really widening access, because if somebody wants to try, esketamine, they come to see me and they say, hey, I think esketamine will help. You have to have the right diagnosis for you to get that. But if you want to go to the psilocybin clinic in Oregon, it's not a medical clinic. The disadvantage of that is that you can't, medical practitioners aren't able to use it adjacent to their practice. They have to go to a clinic. But I think that Oregon just passed a law saying that they will create a pathway for medical providers to be able to provide it. I live in Washington State. Looks like in 2027, they're hoping to start rollouts for educational programs for both medical and non-medical clinics for psilocybin. So, they're really pushing for FDA approval for psilocybin, but I think the world is going to give it to us either way.
Do you see from the non-medical side where you go, because that's really what you see on as far as what's being hyped on social media and the news is where people
Yeah.
are like, I just want to connect with myself, and and they go
Yeah.
get the ketamine drips and they record themselves doing it. Do you think that there's going to be a negative or a negative maybe a repercussion towards being able to use it medically, or even the stigma associated with those medications to even get them covered with medical versus the non-medical use that we're seeing?
Yeah, I mean, I kind of thought of that as like, it seems like there's sort of two pathways. One is, should we create this opportunity for people to have experiences, or
Mm-hmm.
should we create a treatment for people with illnesses? And there's certainly pros and
Right.
cons to each. And it doesn't seem like they're going to have to be mutually exclusive. You think maybe they would, like, if you want, you can either have one or the other. Like I said, it seems like the states are allowing the legislation to create both, so an experiential place and a non-experiential place. Now, it'll be interesting to see what the FDA thinks about that. If they say, well, it's already accessible anyways, so why do we need to prove it? And that
Right.
would be a big bummer if we can't get payers on board and people always have to pay out of pocket. So I think that's your biggest risk, is if you really maybe overemphasize the experiential, non-pharmaceutical, non-treatment part of psychedelics, is it going to pull away from the access for people who might need it medicinally? And I don't know. I hope not. But I mean, I think it's, kind of possibly. But I think a lot of psychedelic advocates want psychedelics available for the experience rather than the treatment. Maybe that's an overgeneralization. Maybe I'll be corrected on that. But I do think there's a spirit of people should be able to have these experiences, whether or not they have the right DSM-5 code, right? Which is a barrier to care. Like, well, technically you have this DSM-5 code and not this DSM-5 code, so insurance will pay for it. But if we create it as more of an experiential thing, so people can have those experiences, and if they come in with an illness and the illness improves, that's awesome, but maybe not the focus. Then I think that's really where the heart of psychedelics may be really laying its cards. If that makes sense.
So my question that I want to jump back in here with, we'll cut all that other stuff out, is could it be what I see mainly on social media and on the news is those who really want the experience, and maybe it's just that is those who have the most influence and the loudest voices than those who actually really need it medically.
I think there is kind of an opposition of voices there between those two things. And I think there might be criticism towards people who want the experience, like, well, it's a controlled substance, it's potentially addictive. Are you just trying to get high? And I think, maybe if more people had psychedelic experiences, maybe they'd be like, oh, I get it now. You know what I mean? And it is different, it doesn't really cause physical dependence. I mean, with some exceptions. I mean, I've had people with ketamine addiction, which have been significant. So there's definitely risks there.
Yeah.
But it's not the same as opioids. It's not the same as benzodiazepines. It's not the same as alcohol. Not the same as marijuana. It's not the same as tobacco. So you have sort of a different entity that could be misused and will be misused. So, I think allowing people access to these experiences, I think people will have and have shown significant improvement in quality of self and sense of self, and I've really appreciated them, and without a lot of consequences. And so, again, with exceptions, which I could talk about some of them, but, if you can really ensure that places are doing this safely, which is how you take things from the underground and create legislation so it's done legitimately, people can have safe experiences where their quality of life is increasing. And I think the benefit of it as well is that some of these benefits you get from psychedelics really don't always fit really well in this box, this clinical psychiatry box. And you'll see this where, well, this trial was negative because technically their PHQ or their MADRS scores, which is how we measure depression, didn't decrease enough. But these other scores of quality of life and sense of self and all these other things robustly increased, and the person's really appreciated it, even though it technically didn't affect the mental illness in a way that we have categorized it. And arguably not categorized it very well. And so, but I mean, there's also a lot of studies that show that it does robustly improve mental health conditions. So I think you can have both. I think we're hoping to have both. And I think the safer we can do it, the better.
Now, where do we stand with the federal guidance and the REMS requirements, and as far as how they're going to shape the workflows and the necessary documentation?
Yeah. And so I can speak a little bit to that with esketamine specifically because I do it every day. And so they, created a risk evaluation mitigation strategy to follow esketamine, which they tend to do for higher risk meds. Another psychiatric med that had a REMS for 30 years was Clozaril, just lost its REMS, but trying to think of other meds. There's other meds too, the psychiatry, and they're used for special monitoring, and they have a database which providers have to log into and input information about their patients they're going to treat. And so that's the extent of the burden with doing esketamine. It prevents people from going to this clinic and going to this clinic and going to this clinic, and not that you can't, hey, I'm moving to the West Side, can I switch clinics? Yeah, but there has to be communication with the REMS program about that. So it creates, the systems are in place and the program is in place. It's just about learning. It's just about uploading forms, which isn't complicated. It's an additional administrative task. And I think that it was, a token to get it approved. The FDA, you can't just put it out there. And so we needed some sort of extra monitoring. Now, the things we're monitoring for, specifically with esketamine that the REMS is really interested in is, dissociation, blood pressure, and diversion. And so, people dissociate, and sometimes they do, and sometimes they don't. Sometimes it's mild, sometimes it's intense. By 2 hours, they're fine, right? And blood pressure, it's such a transient increase that that you're just only going to see it be a problem a couple times in your career if you do it for 40 years, right? Maybe if you're using racemic ketamine, I think people will do the IV ketamine, do chase blood pressure sometimes. But with esketamine, I just haven't seen it affect blood pressure the same way. And then obviously they're not, diversion, as long as you're witnessing them take the medication and dispose of the receptacle, they can't divert it. Although I have heard stories of people walking out with nose sprays. They just need to, there's no way they can do it if you watch them do it. So I'm not sure what those clinics are doing. So right. The REMS thing is, if you don't do those, then you're going to be held liable or accountable as a practice. And so that's what the REMS is certified. So I imagine anything that the FDA will do with psychedelics will include a REMS, including psilocybin, including MDMA. It'll have something like that, where you're proving that you're monitoring them for the amount of time is established. You're proving that you're monitoring for the safety factors. Blood pressure will probably be an issue with those as well. Monitoring dissociation, monitoring for suicidality will probably be something that they would emphasize in the psilocybin one. And then making sure that when you're discharging them, they don't have any symptoms. And if they have, the other thing I think the REMS does is that if somebody has a significant event of some kind, then you report it. And then there's special emphasis on those reported events to make sure that these medications stay safe. And one thing that did come out of that with the Spravato or the esketamine is because of the monitoring and the reports, is they ended up making us do oxygen testing as well, because they saw some people desat in Europe, which whatever. I don't know if I see people desat, but maybe Europeans desat faster. So now we monitor their oxygen. Yeah, it's good. It's good to monitor. It's good that we have a device that sits on their wrist and it keeps a hold of their vital signs the whole time. And it's good to have a clinical picture of their health status for the full 2 hours. It's, I think, a way to keep your liability low. So.
Now, I do want to say for our listeners, if you're wondering what REMS is, that's the risk evaluation and mitigation strategy. And that's usually done in a drug safety program that's required by the FDA. So when you're taking stuff to the FDA, that is what they are looking at. But can you, in the simplest way possible, explain FDA approved versus investigational, as far as how would we share that with patients when we're using these medications? Because some of them are approved and some of them are more of on an investigational basis.
Yeah. There's, and there's even a term called fast track, which a lot of the psychedelics are getting. And so, if they're FDA approved, that the FDA has reviewed it, the pharmaceutical company has, approached the FDA with their science, and they've said, hey, we think we have robust science. And usually, so they'll have 3 phases of studies. They'll have phase 1, which takes a group of people, you give them the medication and make sure it's safe. The phase 2, they take another, 20 to 30 people, maybe larger, and they make sure it works among those people. So then it's effective. And then you have phase 3, which is a much larger, bigger group of people. So you can get the statistically significant data, and you come to the FDA usually with 2 phase 3 positive studies. And then the FDA will look at it, and based off they have an FDA review board that comes in with experts that sort of, I think they pick it apart for a couple hours, and then they make a determination. They make a recommendation, and then 70% of the time, the FDA will follow the recommendation of the review board. And so, so if anything is pending, is in review, they're doing some sort of, they're still in the process of one of the phases. So like there's a couple companies trying to get psilocybin approved. The one that's had the most is in phase 3. Sometimes I think you can come to the FDA with a phase 3 and a phase 2, and they might be trying to do that in order to get it approved. So they got fast tracked. And when the FDA fast tracks something, it's because it's very promising, it has a robust effect, and it's something that's different than anything else that's out there. So I think esketamine got it. There's another ketamine that's fast tracked. Psilocybin got it. I think MDMA got it. But it doesn't mean it's going to get approved. So MDMA got it, the fast track, but they still got denied. And so just because it hasn't, the FDA may deny these medications. And so the, one thing that was interesting with the esketamine studies is they did do 3 phase 3 studies, and only one of them was positive. The other 2 had, a lot of value to them, which they'll emphasize if you ever go to a farm dinner. But they used another study where they looked at long-term maintenance, where they looked at people over a period of time. They took half them off the med and saw which group would continue to do better. Of course, the group that stayed on the med did better. And they said, hey, look, we have another positive trial. And that's how they got the FDA to approve esketamine. And so that's kind of the process of getting FDA approved. So you have the FDA approval, and then in process of FDA looking at it. And then I think before you're even doing your phase 3, probably the FDA is like, get us some more data before we put you on the schedule.
It's interesting to me as we're talking about this, how we have medicinal use versus clinics who are just allowed to just give these medications for the experience. While I would still think that all of the, like the vital sign management and all of the nursing skills that you need would seem like it would also need to be used, even if those are just trying to get experiences versus using it for a medical reason, an actual diagnosis. Am I missing something there?
Well, yeah, it was interesting too when they created the Oregon system, is they really went out of their way and said, you can be a licensed professional and do this, but it is not allowed to act in that profession when you're doing this. So it is completely extra medical. It's outside of the medical field. And so, I don't, it's, time will tell the safety of it all. It's been happening went on for a while. And so, I think, there's risks to these treatments, and there's also, maybe compared to other things that we give to people, they're actually pretty even keel with other things, even though, so even any monitoring is safer than sending it home with them, which is,
right.
And the chances of sort of an event, is something doing more than calling AMR, do you really need to have somebody who can open an airline or put an airway? Or start an IV.
Yeah.
And if you can do CPR and call AMR, I think some of the psychosocial support with people who are not licensed, I think that could be also a good argument of saying like, it's good to have somebody who maybe is trained. Because I've definitely had people in ketamine who got really uncomfortable, and I really took all of my skills to try to help them through that process. And so having somebody who may not have that robust of experience or licensure can be difficult, but if there's good, I looked at some of the programs in Oregon, they're certainly robust. They're not like college degrees, but they're not like a 4-hour online course. They're robust, and you have to do, clinical time. And so, maybe that's sufficient, right. Especially if you have clinical hours.
Yeah.
So.
All right. So moving into actually preparing to use these medications, what baseline screenings do you expect before dosing the patient?
Yeah, the screenings is really nice because then the patient sort of has an idea of their candidate before they even call you. And sometimes they'll still fill out the screenings and still call you, and they'll be like, it looks like you went through the screening and acknowledged that you're not a good candidate, but you can still talk to them about options. But the screening form really helps, help patient understand. It almost helps the patients know what is a good candidate, as far as the contraindications go, as far as, especially with insurance, what DSM-5 diagnoses will get it approved, how many medication trials they need to have had in order to get insurance to be interested. And those seem to be the biggest, screening questions I'm interested in with esketamine. If you're going into a more out-of-pocket cash-based IV ketamine, maybe you're opening a psilocybin clinic, you you don't necessarily have to have those questions on there, where you're worried about insurance. I do think that ketamine, if you're using ketamine medicinally, it's not a first line treatment. So even if you're not getting insurance to pay for it, there should be a burden of finding out that the person has some treatment resistance. But that really isn't the way of psilocybin. So you just want to make sure they don't have any contraindications, that the medications they're on are safe for them with the treatment, and they have the understanding of the expectations. So, the psilocybin, they have the initiation, the pre-treatment meeting, the initiation, and then the follow-up. With ketamine, you have an induction of 6 treatments or 8 treatments, and then followed by weekly. You have to be there for 2 hours. You can't drive. And so those are all a bummer when the patient's surprised by them. So you really want them up front. You want it in front of them before they even show up for the first appointment, and no surprises about, I hope you still have to be here another half hour and you got to get a ride. So I think those are the most useful screening forms. And if you're using insurances, esketamine is a little bit of a game with insurances. Some insurances cover it well and some don't. And so knowing what your patient's insurance is and kind of investigating it is a good front step. It's easier to do it before the patient comes rather than after.
Right. Now, do you have these are the exclusion flags that just stop you in your tracks before deciding to give them the treatments?
Yeah. Esketamine specifically, there's a couple of absolute contraindications, and I'll pull them up real quick. But the things that I think I see most common are this is the patient hasn't tried enough medication. It's kind of a bummer when you're kind of going in front of the insurance company and you're having a patient there who just hasn't been on enough medication. And the other case of that is that a lot of times if somebody's only been on one medication and they're looking to treat depression, really they've been on 2 medications, but maybe one was just an issue of side effects, they're going to have a really good chance of benefiting from another med trial. So whether or not we should be gatekeeping Spravato for that, it's ultimately at this point, it's not up to me because the insurance will. But they need to have
insurance is gatekeeping. That's what you're saying.
Yeah. But I think there's sort of an ethical thing there where Spravato isn't a first-line treatment. And if someone comes to you and they have been on a medication, one failure, one side effect, and you're like, I really think another medication's going to be fine. I think you're going to benefit from another medication. And I think I can think of one that you won't have that same side effect. That's informed consent. And I think we really, really need to make sure we're doing that. And sometimes people are just not a candidate for Spravato despite what the insurance thinks. And we need to make sure that we're not just opening the door for everybody who checks all the check boxes, that there's discernment there, and we're making sure that people are safe. Substance use, active substance use is not we got the screen for that. We'll do a drugs test. A history of substance use is not. I have a lot of people with history of substance use. I think there's even some data to support ketamine in sobriety. Pregnancy, they can't be pregnant. They can't be breastfeeding. You gotta have to have conversations with people. If pregnancy is a physical possibility for them, they may not be planning on getting pregnant, but they also may not be avoiding it as carefully as they should be if they're on a medication like that. It's not that it's identified particularly as problematic, but they just have no idea. They have no idea what it would do. So you need to make sure that their blood pressure has been stable. They can have a history of hypertension, but it needs to be treated. And so if their first appointment, they're coming in with a high blood pressure, you want some context there. Insurances used to require us to send them the blood pressures. They've stopped in the last year or two. But we use, they still want if they want information, if they want records, they'll send them the blood pressures, but they used to want it in the PA. What's their baseline blood pressure? They've stopped asking for it, but the biggest issue with blood pressure is it might spike the blood pressure. So if their blood pressure is already teetering on that edge and it's going to increase it 15%, and now you have to do something about it. So you need them to get treated for their high blood pressure if they haven't already. If they're treated by high blood pressure is great. They need to have hepatic impairment, severe hepatic impairment, arteriovenous malformations, aneurysmal vascular disease, or history of intracerebral hemorrhages. Those are your absolute contraindications, and breastfeeding. Those are the not breastfeeding, pregnant or breastfeeding. Those are the absolute contraindications, and also the hypersensitivity to ketamine or esketamine, which is a mostly undocumented phenomenon. I think that maybe has happened before, somebody having a ketamine allergy, but largely is incredibly rare.
So most of these patients that are being treated with psychedelics it's more for depression, Is there anything else that they are treated for besides depression with these medications?
I think that, I mean, I think within, that's another big burden with insurance and esketamine. It's not even depression, it's major depressive disorder. So it's non-bipolar depression.
Okay.
And that is another sort of sticky, if they have a bipolar diagnosis, it's not approved for bipolar, it's off label, and insurance will deny it, absolutely deny it. And so you kind of even have a question, like, it's like my number one question is, I have been diagnosed with major depressive disorder. Number two, I do not have a history of manic episodes or a history of bipolar diagnosis, right? Because it's a big hiccup, because everyone in their head are like, no, I do have MDD and I have bipolar. You know what I mean? And we just haven't done a good job at communicating that. According to the DSM-5, the bipolar is exclusionary. And if you have a manic episode, you have bipolar and not major depressive. And Spravato is only approved for major depressive.
And it
so
seems
you only
like
have that one indication.
The contraindication would be active psychosis, right? Not necessarily bipolar technically, but we're saying if you have bipolar, then you're automatically excluded.
Yeah.
That doesn't seem.
It just was. Well, and it really should be approved for treatment-resistant depression,
right?
Not an MDD. Treatment-resistant depression is the disorder they invented for this illness, for this medication. It's not in the DSM.
They invented.
But it should include. Yeah, it shouldn't be inclusive. It should be treatment-resistant major depressive disorder or bipolar. But and that's the indication they got. Oh, that's the indication they sought out. But the FDA interpreted it as MDD with TRD, and major depressive disorder with treatment-resistant depression, because they only studied MDD patients in the study, and they excluded people with bipolar in the study. So that's why the FDA went that direction. And so the insurance company is not going to pay, $1,800 a treatment, or $60, I don't even know this amount of money for a treatment if it's not specifically on label, and not interested in exceptions right now. So there is a new medication. It's not given a name yet. It's ketamine. I think it's NRX 100. And it is an intravenous ketamine infusion. The way they're able to get it branded is they've taken out what's the word? They've taken out an ingredient in ketamine that I've just lost my words. Is a preservative. They've taken out a preservative in ketamine, and now they're calling it. Now it's preservative-free ketamine. So it's going to be brand name NRX 100, and it's an infusion for suicidality. It's got fast tracked.
Okay.
It is depression with suicidality is what it's approved for, and they've included bipolar depression, and it's positive. So there's data that ketamine and probably esketamine are safe and effective in bipolar depression. If they come in manic, or they come in with incredible mixed features, they're not a good candidate. But if they're really depressed and they're not in a manic episode and they're on a mood stabilizer, so they're on lithium to prevent mania, or they're on Depakote to prevent mania, they're on carbamazepine to prevent mania, or they've really established a long-acting, antipsychotic, and they have not had a manic episode, and you're comfortable as that is maintenance, then by all means, give it to somebody with bipolar depression. And I've treated patients without esketamine with racemic ketamine with good success who've had bipolar depression. So, and and as long as they have mood stabilizers on board, there's not high risk of causing mania. I mean, you have to educate them, but it seems like off-label use, you can do it however you want. You go on ketamine, you go on an IV ketamine website, and they said now approved for pain, depression, PTSD, GAD. You know what I mean? They're listing every diagnosis they can think of, because there's usually a study out there that showed that it helped. You know what I mean? There was recently one for PTSD and ketamine that was effective. So I mean, and the same thing with psilocybin. You're going to find this thing where if it's not FDA monitored, if the FDA approval, if you're allowed to open up a clinic, it's not brand name, you can buy it yourself, you're using it off label. As long as there's a documented benefit out there, as long as a study has looked at its safety and effectiveness, and I've seen lists on these websites, they're MDD, bipolar depression, PTSD, generalized anxiety disorder, they're listing OCD is usually on there. And so there's a lot of high claims there. And I think that, maybe if you really give somebody a really good sense of well-being, these other problems might dissolve to some extent. And I also think that mood disorder is a lot more of a pillar than we've really given it credit for. And so using a really potent antidepressant, you're going to find that comorbid conditions tend to either go away or they tend to reduce significantly if you're treating their mood adequately. So it makes sense that, ketamine is a really robust antidepressant that OCD symptoms will potentially improve, or anxiety and symptoms will improve, or potentially trauma symptoms can improve. So, and one thing that we tend to do with other psychotropic medications is we call them by their intended effects. So,
Yeah.
serotonergic medications are branded antidepressants, or the antipsychotic medications, or the anticonvulsants we use in bipolar are called mood stabilizers. Where we call benzodiazepines anxiolytics if you're getting really fancy. So we do sometimes use fancy language to try to pull away from some of the stigma that happens in the original, because a lot of times those antidepressant, mood stabilizer, or even antipsychotic, those aren't really that accurate. We tend to use antipsychotics for mood, and some of them don't work that well for psychosis. And so that movement does try to take away the scariness of some of these medications for the stigma. I use antipsychotic medications all the time because it treats mood, very effectively. But 1 out of 2 times you say the word antipsychotic to a patient and now they're nervous about it. But I don't want to be dishonest, so I always do. But I mean, it's you got to tell them. But then you try to create a caveat, and 1 out of 2 times, you're like, or maybe 1 out of 3, they're really, really nervous to do it because it's got all that stigma. Or like even my favorite medication, the most effective medication ever, is lithium. And you say that to anybody, and all of a sudden they don't even know where they're getting the stigma from, but it's coming like a slideshow. Right. Maybe it's a Nirvana song, or you know what I mean. And
their childhood back in the 60s. Yeah.
So I think fighting stigma, especially with psychotropics, is something that we're just gonna do all day, every day. I don't think psychedelics is gonna be that much harder to fight the stigma. People misuse ketamine a lot, and we brought it into the clinics with great effectiveness and safety. And people abuse Seroquel, and they abuse Wellbutrin. I mean, the people are just really fancy with how they misuse things. And so the burden is always going to be on us, clinicians, to protect our patients from diversion and abuse. So.
Right. And just thinking, okay, psychedelic drugs, when patients hear the word psychedelic, it just seems to have a stigma. It seems to bring a fear. It seems to bring maybe even some embarrassment with the fact that I'm having to use psychedelics. I don't want to use psychedelics. Yeah. And so I just wondered if we would be changing our language, if you thought you saw that coming.
Yeah, and I feel like I see that with all the other medications too. And even with Spravato, I'll have patients come in and be like, I thought about doing this 2 years ago. I wasn't ready. I didn't know anything about it. I was nervous about doing ketamine. I knew ketamine on the street. I heard about Matthew Perry. Yeah. And then they do go on a journey of I'm still struggling. I'm going to look more into this and look more into this. And then at some point they become ready. So I think that stigma does delay treatment for people, but you really, really don't want to put somebody in a treatment that's not ready for it. If they're ambivalent at all, or they're on the fence, or they have some really big concerns, I have some big concerns because it's not very likely to be effective, and it has a high risk of being tolerable because the person isn't really bought into it. And so I really usually encourage those people to either an alternative that might make them less nervous, or giving them more time, because people need to do these treatments when they're ready for it. Yeah. And stigma and that sort of thing plays a big role in all the medications. I think psychedelics will be similar.
Right. And it's just interesting to see where we're going with this and how it's unfolding. So it'll be interesting to see where it goes. Yeah.
We just get to observe it. It's going to be very interesting for sure.
Yeah, for sure. I'll meet with you again in 10 years. We'll see where we are.
Yeah, let's do it.
Probably 5 years, honestly. I mean, we probably are going to see some changes in the next 5 years, probably.
We can meet up at a psilocybin ceremony. We can do psilocybin together. How's that sound?
So tell me about informed consent. How do you structure your informed consent for dissociation, for functional impairment, including post-safety visits if that's necessary? What language do you use? How do you set those expectations for the patient?
Yeah, you want to, kind of do two things. You want to kind of caution your patient, but you don't want to freak them out. You want to be very honest about what it is. But the truth, especially with esketamine and ketamine, ketamine maybe is more predictable because you give it IV, or some people give it intramuscularly. I can usually, if I'm giving a good enough dose, I can usually predict how it'll work. Esketamine is not that predictable. And usually because it can be very dissociative, or it can be very mild. And depending on your patient, they might be really interested in it. This might be their first, they might be interested for the psychedelic effect. And it's there's a 50% chance you're not going to have one. So you kind of have to caution them, but also sort of, I try to sort of, also sort of dissolve some of the anxiety of the sort of the limits to the effect as well. But yeah, you really want to give as much information as possible, and you try to put things in words that the patient understands. I think like dissociation has a lot of different meanings, especially with people with trauma. PTSD. People are like, "Well, I dissociate because of my PTSD. Is that going to make that worse?" And I think that I think that I've heard somebody else write and call it dreaming. And I think with ketamine, it is very dreamlike. When you do dissociate, you're out of your body and you're kind of dreaming. It's not, usually doesn't have a lot of visual aspects to it like you would have with other psychedelics. So it has to be kind of in your head and you're kind of floating. But you do want to caution them that you might get really anxious and it goes away, or you might throw up, you might get really nauseous. And then I'm honest with how many times I've seen these issues, and it's really few. But what we did when that happened and what their options are if the experience is them, we're pretty quick to intervene. And so I think that is the, with esketamine, it is kind of an indefinite thing. It doesn't have to be. You want to create set of expectations with the patient at first. Some patients are interested in doing a certain amount of time. Most people are interested in getting better. And so you kind of just wait to see how it works. And sometimes it works really well and the patient ends up leaving treatment, or sometimes it partially works and the patient really identifies as ketamine as a reason why they're getting as much relief as they're getting, and they do want to stay in treatment. So you don't have this built-in post-treatment, meeting or debrief, right? Because you can talk about it the next time. Where there's a problem, then I will talk to them in between. But usually you could talk to them at the end, and then they come in for the next treatment. And you'd be like, "Hey, how's it going? How was your last treatment? How did you do in the days in between?" But it is very clinical and very medical with the esketamine insurance. We think when you see like a psychedelic ketamine assisted psychotherapy, where maybe they're just doing 6 treatments, a therapist is in the room with them, a therapist brings them out, and they've created all these pre-expectations with a therapist in a beginning session, then yeah, that post-session is really important to sort of recall those therapeutic goals, because you're using ketamine as a tool for the therapy. And I think that's the same thing with MDMA and psilocybin, is those processing, really, you're really meant to sort of identify goals, identify problems, use the psychedelic experience to sort of process or expose those vulnerabilities and have the experience, and then meet up with the therapist in between to really, or even after, to sort of say, okay, how did you do? And sometimes those therapy sessions are long. So I've never really participated in those, but they have, I'm sure they have a lot of things that they intend to go through. But it's, as far as the future of how that therapy is embedded, that was a big problem with the MDMA FDA approval, is the FDA was not interested in improving therapy, and MDMA treatment was, therapy was essential to the way they did it. It was a specific therapy, specific psychedelic related therapy, and they wanted the FDA to not only approve the MDMA for PTSD, but it had to be paired with this therapy that the people would need to be trained to do. And I think the FDA was, I think it might have highlighted some of the other issues that they had, because they just didn't know, they don't approve therapy. And if they had maybe used CBT, or they'd used another evidence-based program, which, I don't know how well that would work with psychedelics, maybe the FDA wouldn't care, because we already know the science already supports it. But now you're seeing like psilocybin trials, they're not, the phase 3, they're not using, they're like supportive care, non-directive supportive care is what the people is receiving. But they're not receiving a therapy because they know the FDA that'll red flag them and they won't be interested in approving a therapy. Whether or not you can go later and do both, is how you interpret insurance codes. But
now I want to go back to the adverse effects that you kind of mentioned, and I know you said you don't see them often, but some of them I'm sure you do see, like the nausea, the vomit, maybe even moving towards vomiting. Can you walk us through, so let's start with blood pressure, because you've talked a little bit about there's that typical rise with the ketamine and the esketamine. So what does that look like, and when would you start to call for medical management with that?
yeah, it's really infrequent. I mean, I don't know. I should have wrote down the statistic in the study, but like 1 out of 5 that I've seen, probably close to that in studies, maybe it's 1 out of 3 in the studies, got a blood pressure elevation, non-significant, not clinically significant. And it's pretty common, but it's not the rule. Not most people. Some people have a little bit of a drop. Maybe that's just as common. But it's never a concern. There would be, we have you're supposed to get a vitals, you should put initial blood pressure, and that's usually where the problems exist. Someone comes in their first appointment or comes into one appointment, the blood pressure check it, and it's wild. And you're like, oh no, we
can't do this.
The blood pressure's too high.
Yeah.
And a couple of steps you can do is, one, get a manual. I've had to have that with conversation with staff. It's like, what was the manual blood pressure? And they're like, go get a manual. Do not trust.
Right.
I got the most expensive blood pressure cuff from Walmart. Go get a manual blood pressure.
Right.
And confirm it. And ever since we're using these wrist ones, are really expensive blood pressure. Those are super accurate. So those tend to be super accurate. But get a manual to confirm any weird blood pressure. And then if they're still hypertensive, did they rush here? Did they, you know what I mean? Are they super stressed out? You know what I mean?
White coat syndrome.
Yeah. And so usually, I mean, I think we've sent home like one person, but it was also, we had also had a conversation with them about getting their blood pressure treated, and they hadn't yet. I think maybe we had to cut another patient off just because of just consistent issues with their blood pressure meds. But usually you can let them chill for like 20 minutes. We did carry clonidine. We might have clonidine. You can give them some clonidine. I don't know how fast I mean, I think we've done it before. If it works in a half hour, that's great. It just depends on how long you have that room for and how long that patient has. Are you ready to be here for 2.5, 3 hours? We can give you some clonidine and see if your blood pressure drops in the next step. It just depends how busy your clinic is.
Right.
In the middle, you really don't want the blood pressure to rise 20%, and it just doesn't. I mean, it's possible, I guess. But if you're going to intervene, maybe if the confirmed blood pressure is 180 over 110, then you can intervene and maybe you just send them out on an AMR. There's some blood pressure medications you may want to feel equipped to give, maybe clonidine. And so, we're all psych nurse practitioners. And so we probably would, if the person's symptomatic and blood pressure is high, maybe we would try to treat it, but I think there's a good chance we would send them away to make sure that they're going to be okay. So.
Yeah. All right. What about dissociation, panic? What if de-escalation, grounding? What do you do there?
Yeah. It does happen, and it happens a lot less with the esketamine. I think with IV ketamine, they're giving lorazepam a lot to manage that, to offset it. If we're not giving lorazepam IV, it probably doesn't act fast enough. Maybe it does. Usually people just sort of go through it. Maybe it takes a half hour. And if they get kind of in this kind of like K-hole, really anxious, effect, they tend to be really preservative on where they are. They're really scared. They usually want to go home. And so they just need someone to sit there. And you can't really negotiate. There's just sort of this like, I was like, okay, I just want to, one guy was, telling me want to go home. I was like, well, we got to call your ride. He's like, okay, I need you to go call him. I was like, okay, but I need you to be safe first. So I just sat there and just said, well, somebody go call him as soon as you're safe. So, it's just sort of this rehearsed, and I just sat with him, and then he, you try to talk them through what they're going through. It's like, you're just having, it's really, you have a lot of experiences right now. If you can listen to some music, usually you can get them to listen to some music, and then if they can kind of be on their own, they're not going to interact with you as much, and then they will come out of it. They kind of snap out of it, and then they're usually not super happy with the experience because usually it's really intense, but it doesn't seem to be trauma printing. They tend to, I think all the patients I've had these experiences, maybe with one exception because it was his first time, came back and was able to tolerate the medication. Either we did a lower dose or something. It's super rare. It's like maybe I can think of 4 times with esketamine, maybe 3 times with esketamine. When we were doing the racemic ketamine, it happened a little bit more, but we did the dosing a little differently, and we started pretty low because it's just a bad day when it happens, and the patient's not having a good time. So you can give IV Ativan, but it's just better to sit with them and reassure them, and they're kind of in crisis mode, and sitting with them is the best way, I think, to help.
Kind of like a sitter script, just sitting with them, having a script that you're using just to try to bring them back to reality and calm them down. Because I could see myself I could see myself panicking if I tried it, because I like to be in control, and so to feel like I'm out of control brings me panic personally. So I could see that happening if I tried this.
Yeah. And usually it's just because they get a little bit, I think there seems like a window of therapy with ketamine, and maybe this is the same for other psychedelics, and you go a little higher than that, and it just gets really uncomfortable. And sometimes people will have like these close to death experiences, then they're going to die. They'll think that it'll never end. That's what they're panicking about. They think this will always be the case. They're afraid they'll always be in this state. And yeah, but I mean, it's very self-limiting. You're able to sort of sit with them
Right.
and help them. So.
What about the nausea and the vomiting? Do you do like the prophylaxis versus wait and see and treating it if it happens?
I usually give people a choice. I usually ask, how do you do with meds? Do you tend to get nauseous? People who tend to get nauseous get nauseous. People who don't. Obviously, exceptions happen. I've had people do treatment for like months and randomly get nauseous, and it just happens. I tell people we have these little blue throw up bags that inflate. I tell them they're in every room, and I just be like, "Hey, you're allowed to throw up." I try to normalize it, because if they throw up, they throw up. It's not. I mean, it's going to happen. Happens pretty infrequently, but it's going to happen. Usually Zofran does a trick. It's a little bit more. It's more effective. You get it on hand beforehand. Usually, if they're naive to Zofran, 4 milligrams will work. If they're not naive to Zofran, you might need 8 milligrams. There is a there's other meds you can use. We did use a scopolamine patch once with somebody who just who had like there's sort of this mixed match of like, does the risks benefit equal each other? She was having significant benefit, life-changing benefit, but just always was vomiting every treatment. And so tried the scopolamine patch, and that seemed to help a little bit. And then her other provider, who was a Spravato provider as well, I didn't know about this option, had given her lidocaine to gargle. And so she's gargling lidocaine, and it seems like, because the medication goes in your nose and then it drips down the back of your throat, and it seems like a lot of her nausea vomiting effect is from the stimulation from the back of her throat with a really bitter taste. And so when we numbed it, probably 2 out of 3 times it really helps. Sometimes it doesn't. But that's the other thing. I always tell people this: Spravato tastes gross. If you tell them, they don't care. If they don't tell them, they're bummed. So you got to tell them, because then they don't care. They're like, oh, it's kind of interesting to them. Oh yeah, it is really gross. Yeah. But if you don't tell them, it's a big surprise. Yeah, it's a big surprise. So I try to be, and that's a good approach to give people kind of that kind of, because usually that's pretty non-consequential. They're like, oh, okay, I don't care. Usually, if the intranasal thing is a problem, intranasal thing's a problem for the person. It's not the taste. So.
Right. Okay. So move to readiness for discharge. How do you determine their stability post dose? What symptoms are you looking for? How do you know when they're ready to go home?
Yeah. So like I said, most people don't have the blood pressure issues, and so that's a potential thing. But really, very rarely is that someone, okay, we're watching this person's blood pressure before they leave. I don't even think I've had that conversation before. So usually it's just the dissociation, which wears off pretty consistently around an hour mark. So usually the person's there for another hour just hanging out. Sometimes it lasts a little longer than that. You have people kind of walk into someone's room, and sometimes you get this effect where people are like super sedated, like the second half. And so you walk in there and they're just like asleep. And so, but just because they're affected by it doesn't mean they're safe to discharge. If they have a family member there and they can walk, I mean, they probably already gone to the bathroom because they're there for 2 hours. The ketamine makes you have to pee. So they've already been walking around. And so you kind of get them up, and if they're safe to go to the car with a family member, then they're safe to go home. And sometimes they're not dissociating at that point, but they can be a little out of it. So there is sort of a low window of being like, oh, you're still sedated, you need to be here for an hour. It's like, oh, if you have someone driving you home and you go home, go to bed, you're safe to go. So, and I haven't seen like a perpetual dissociation where the person at 100 minutes is still, it really wears off consistently between that 30 to 60 minutes, and then they're maybe they're kind of out of it, but they're back on planet Earth. So
now, how do you coordinate? I know you said that it all goes back to insurance, as far as and studies being able to combine the medications with, say, pre and post sessions. But I mean, how do you coordinate with, say, therapists, or even with them coming back to see you for pre and post sessions, especially if it's all investigational?
You're right with the other, I think that might be a big challenge. It just depends on the how big the mental health world is where you're at. I try to get as many people's cell phones as I can, so I could text people, and I can, and they tend to refer people to me. So I know their therapist, I know their primary care, because that is the easiest way to collaborate. But yeah, sometimes it's a real burden to try to connect with somebody's other provider. Usually therapists are really up for it. And the reason they're there is they're therapists. And so they tend to be, so, I think, like I said, Spravato does tend to be this indefinite thing. Sometimes ketamine tends to be this indefinite thing. So, in sort of informal checking in with them is usually what's needed. If you really have a finite session, like one treatment of psilocybin or a series of ketamine, I think that kind of asking the patient, who are we doing this in collaboration with? Is it your therapist? Is it your at-home therapist? Is it your psych provider? And then creating an availability to collab with them is probably what most people just do, is just sort of be available to it, whether or not they plan a meeting or not. I think a lot of times the patient can kind of bring forward what they learned, but usually if there's a problem, it's when people connect.
Now, I find it interesting as you've kind of been talking about insurance, and then there's kind of this removal of the medication versus the therapy sessions. And there was a study in 2021 from the American Journal of Nursing that actually said that the prep, the dosing, the integration model is core to the therapeutic use and safety of psychedelic drugs. So I'm just finding it interesting that insurance is kind of making it difficult, or is it the research studies themselves that are making it a little bit more difficult?
Well, they did that in the MDMA study, and the insurance was going to approve it. There were certain codes for each step. For the pre-appointment, there was a code. For the treatment session, there's a code, and for the in between, debriefing sessions, there's a code in the final one. So each session, the hour and a half that they met in between, those all had specific psychotherapy, psychedelic assisted psychotherapy codes, and even Primera put them in their policies, in anticipation of this approving, and it didn't approve, but you did see the insurances start adapting it. So, just because it's not therapy doesn't mean that they're not gonna have integration or follow-up appointments and build that into the system and ask the FDA to acknowledge that. So I'm not 100% sure, but I imagine if that is the status quo, that's the consensus, that there will be sort of this integration that'll have an insurance code available for people to use, even if it's not therapy.
Right. Now, I really find it interesting that the psychedelics as a class, they were actually studied very extensively between, I believe it was 1943, and they were just halted in the 1970s, because that's when we had the Controlled Substance Act. That's when it came about.
Oh, right.
So I feel like there's such a huge gap. We could have been so much further along in the research and the understanding of this drug class if it wasn't for this halt in the 1970s. So just seeing it come back, seeing where it's going is very interesting over these last, I feel like, 5 to 10 years, it's really been making a comeback.
Oh yeah, 100%. Yeah. And I think people in the psychedelic, field have been like, oh, we've been at this for the last 30 years, and they've really been chipping away. I think there's been a lot of man hours of just chipping away at the perception and the stigma, and doing these sort of edgy treatments to get safety data, mobbing for control one license so they can do these studies and stuff. I think there's been a lot of effort to sort of shift the perspective, and it does seem though that this era is particularly receptive to it. Right. It wasn't the work to the 90s, it wouldn't have worked in the early 2000s, but this era is a different group of people with a different economy and different highlighted issues and
different viewpoints and understandings. Yeah, for sure. So
kind of settled in our lap, and now I think it'll thrive.
Right. Now, as we get ready to wrap this up, for nurses and nurse practitioners who are looking to go into this area, what types of training do you think that they need to have?
I think the training will be clear. Psilocybin will have specific trainings you have to do, and I would say do them. You'll be the first people on the block doing it, and that'll be really cool. If you're interested in getting started right now, I want to do like ketamine assisted psychotherapy. There's a lot of cool ketamine assisted psychotherapy. I did it's called resilience training with Jennifer Monjoy down in Arizona, and she also comes up to Washington once a year. And that was a lovely training. It was really cool to do ketamine assisted psychotherapy training. And so and then you can get a hold of ketamine right now and start offering psychedelic assisted psychotherapy. So doing esketamine, whether or not you need a specific training, I think there might be a new one out from the DuPrat University, but the pharmaceutical company will show you how to do it. And there is just, the hardest part is getting insurances and figuring them out. And you just got to kind of figure that on your own. So,
yeah. Also, I think just make sure you're trained in things that you would need if you were working underneath the psych umbrella, which would, of course, be like the de-escalation, motivational interviewing. Trauma-informed care is really big, I think, in this area. And then really just understanding what those REMS competencies are for documentation and for medication use. I think those are really important for nurses that are going to start looking at this area and moving into it. But thoughts on that? Yeah. Agree.
Oh yeah, definitely. I think a lot of those would be embedded in those kind of things. But yeah, for sure. I mean, use this. Good nurses have de-escalation abilities and have incredible communication skills, and so you'll find a lot of those come very intuitively. But you also might find that these people are interacting with me a little bit differently than my other clients are. So you need to have some ability to sort of maybe sidestep your go-tos, but learning a specific motivational interviewing, de-escalation technique, trauma-informed care. Great way to do it.
Right. Well, this time it just flew by, Nick, and I have so much more that I want to know, and I'm sure there's so much more our listeners want to know. So if we want to stay up to date on this information and on this topic, what are some places you think we should be looking at?
There's a cool Facebook page called Open Nurses that I like to follow quite a bit. I think that might be, for nurses specifically, the coolest one. I think, following whatever state legislation you're in, you can kind of look it up and see. But yeah, I think there's lots of resources. That's the one I'm mostly plugged in with.
Yeah, I definitely think as the landscape is changing, as far as laws and rules for these medications, we definitely need to be watching our state and federal guidelines that could be coming out. So I'm sure there's something sitting in every state at this point, or at least most states. So, all right.
Yeah.
Thank you so much for sharing your knowledge in this area. This was so informative, and it was so eye-opening just to kind of see where we're headed, where we've been, and then just seeing it pick back up and seeing where we're headed. So for our listeners, psychedelic assisted therapy is no longer, it's not really alternative medicine anymore. It's becoming, we got protocols now. So we have care, we have federal guardrails, and the FDA is really signaling exactly how trials must prove safety and efficacy in this area. You're already seeing REMS for esketamine. It's already there. Trials, of course, are continuing to show meaningful symptom drops in treatment-resistant depression, which is exactly where patients need new options. And really the differentiator isn't the molecule alone, it's the nursing. From accurate screening to calm, skilled monitoring and crisp documentation, nurses make this care safe, ethical, and repeatable. So let's build the workflow, let's respect the physiology, and let's keep the therapeutic framework intact. That's how our profession helps to bring this field into the mainstream without losing the plot of taking care of our patients. So to our listeners, I encourage you to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.